Hello, my name is Rachel Robinson, and today I will be discussing the clinical findings for pneumothorax. A pneumothorax is when air leaks into the space between the lung and chest wall, known as the pleural space, and this is caused from either a hole in the lung or chest wall, causing air to leak, and this causes part or total collapse of the lung, known as atelectasis. It is potentially life-threatening. In this photo, you can see air filled within the pleural space where it's not supposed to be, compared to a normal lung where there is no air within the pleural space. Patients may present symptoms like shortness of breath, pain during inspiration, chest pain, or pressure, as well as lightheadedness. Every patient may not complain of all of these symptoms. It depends on the patient and the situation, but these are the most common symptoms for pneumothorax. Risk factors include smoking habits, lung disease, tall, thin young men, thoracic trauma. This is common for motorcycle accidents when they experience a blunt force trauma to their chest, which could cause a rib fracture that could puncture the lung, leading to pneumothorax from leaking air of the cavities. Invasive procedures, common in the emergency room settings for blunt force traumas and other traumas. Patient having a family history of pneumothorax, or themselves having had a pneumothorax before. All of these things are things you want to, when you're interviewing your patient, asking them if they have the smoking habit, if they've experienced a blunt force trauma. The risk factors are interviewing things as well that you're asking of the patient for what they've experienced, what their family history is, their history is, if they've had any recent procedures. A patient that has come off of or is currently on a CPAP or BiPAP may have a pneumothorax. If the lungs get overinflated from too much positive airway pressure, this could cause the alveoli to rupture, leading to the air leak for pneumothorax. Vital signs, their pulse, they will likely have a high pulse, a strong pulse above normal, known as tachycardia. Respiratory rate will be high as well for tachypnea. Their oxygen will be low. Their temperature typically will be normal unless they have anything underlying illnesses along with this. Blood pressure is typically going to be low as well. They will be hypotensive. Every patient, again, is different. Some of these factors may not be presenting for a pneumothorax patient, but these are the typical guidelines of what's common for these people. Upon patient inspection, not always, but sometimes they will have a cyanosis of extremities due to low oxygen. You can see that over here. This person has blue fingertips, and it could be on some of their other extremities as well. So you'll want to look at those when inspecting them. Bruising. Bruising is common if there was pneumothorax due to the blunt force trauma. They could have bruising over the affected area. This patient, you'll notice having an increased work of breathing. They're going to be using their accessory muscles when they're taking a breath. Nasal flaring is common too. They're trying to breathe and they're working extra hard to breathe. A trachea shift can sometimes be seen by looking at them, and their trachea would be shifting away from the area of the pneumothorax. And jugular vein distension, JVD, is not always, but sometimes can be present here with pneumothorax. Palpation, the patient will typically have a reduced chest expansion on the affected side. Sometimes a grating sensation can be felt from a pleural friction rub. Percussion typically will have an increased resonance on the affected side, and the auscultation will be diminished breath sounds over the affected area where the pneumothorax would be. And again, all of these things may not be present, but these are typically what this patient for pneumothorax would appear. For digital diagnostic imaging, for pneumothorax common will be done with either a CAT scan, X-ray, or ultrasound. And I'm going to go over what all of those findings look like for those different modalities. For an X-ray, the trachea and heart organs within the mediastinum will be seen shifted away from the pneumothorax. That air pressure is going to push those things away from where it's occurring. A diagnosis may be made for this condition with the presence of a pleural line seen on an X-ray. You can see it right here is your pleural line, which is not typically supposed to be found on an X-ray unless there is something going on with that patient, as well as absent lung markings where they're typically present. and air in the pleural cavity. There's not supposed to be any air in the pleural cavity, but that's why we have that line, because we can see that air. And these x-rays will appear more radiolucent. They'll be a little bit darker in the affected areas than where a normal healthy x-ray would appear to be for a chest. For ultrasound, absent lung sliding and typically for ultrasounds, comet tail artifacts will be present, but for this condition, those things will be absent where they are typically found for a healthy person. For CAT scan, the CAT scan is known as the gold standard from what I found in my research for pneumothorax. CAT scan is preferred because it shows the exact size of the pneumothorax, where some of the other two modalities don't show you exactly the size of what you're working with. And as well as X-ray CAT scan has absent lung markings, and it does appear more radiolucent than what a normal CAT scan would appear. For this discussion, I just want to bring back to, although all of these things are what are typically found for patients with this condition, this is not 100% going to be true. Every patient is different. Some patients may have different symptoms, as I've mentioned. And these things are all when you go over their patient history. Just because they do have a history of smoking habit, that does not mean they have a pneumothorax, but a combination of these things will be present, and things to keep in mind when interviewing your patient to see how at risk they are for a pneumothorax, and knowing the background information in the setting, if there are any traumas, recent procedures. Those are all things to keep in mind. And as I said, vital signs, these may not always be true, but this typically is what we will be seeing for patients with pneumothorax. Same with this. Trachea shift, I believe, will always be present. It just, depending on the patient, you might not be able to tell just from looking at them. Jugular vein distension may not always be present. Increased work of breathing almost always will be present, but it still does just depend on the patient. And cyanosis is more of a rare occurrence, but it is something to look out for with low oxygenation. And again, this is what's typical found: diminished breath sounds, increased resonance, reduced chest expansion on the affected sides. It does depend, but typically this is how the diagnosis appears. Another thing I wanted to mention is different modalities have advantages and disadvantages. They do consider CAT scan to be a gold standard for diagnosing a pneumothorax. As you can see, the exact size, where the other modalities you can't tell how large it is. But with CAT scan, there is more radiation. So for children and things like that, you might want to do an ultrasound opposed to the CAT scan. It really does just depend on the patient. Every patient is different. Typical findings may not always be present. These are my sources. All of the sources were from peer-reviewed sources, and then I use my book as well, the Wilkins Clinical Assessment in Respiratory Care. And that is the end of my presentation. Thank you.